Hello, I'm Shannon Brooks. I am here today to discuss opioid use and treatment during pregnancy. Opioid deaths in Massachusetts are still ranked as the eighth for the highest drug overdose deaths in the United States between 2016 and 2019. More people died from drug overdoses in 2017 than from firearm deaths. 10% of pregnant women admitted to addiction during pregnancy in Massachusetts alone, and 25% of pregnant women use one or more addictive substances in the US. Suboxone or Subutex. What are these medications? These medications are partial agonists. They are category C classification for drugs. They help prevent withdrawal, diminish cravings, make it difficult to produce a high, increase treatment retention, and they are dispensed by a treatment program by a provider who is medically indicated to dispense these particular medications. The Suboxone competes with other opiates and blocks their effect, displaces heroin and other opiates from receptors, suppresses withdrawal for 24 to 48 hours. It is a safe alternative to methadone during pregnancy and can be prescribed, like I said, by the MD that has undergone training and referred to a treatment program. The goal is for safety of the mother and fetus and decrease opioid use during pregnancy. Maternal and fetal risks. Maternal risks are if the mother is not treated, she has placed herself higher at risk for a relapse. For most of these women are at high risk for stress or violence in their home life. Difficulty controlling pain during their delivery happens. They are at risk for overdose, lack of prenatal care, infection, perinatal mortality. They are at risk for higher risk for preeclampsia, third trimester bleeding, or abruption. The babies are at risk for neonatal abstinence syndrome, opioid withdrawal, long-term health and developmental problems, low birth weight, jaundice, fetal birth defects, sudden infant death, and passage of meconium at the time of labor and delivery, and prematurity. But taking the Subutex and Suboxone can help outweigh the risks of not taking it. Screening tools. So there is multiple different screening tools that we can use in the office. We want to screen for substance abuse at the first prenatal visit. One of them is called the 4 Ps. ACOG recommends the T-ACE, and the other one is the SERP-P. The 4 Ps, you're going to ask the patient, have you ever used drugs or alcohol during pregnancy? Have you had a problem in the past with drugs or alcohol? Does your partner have a problem? Does your family member have a problem? Although studies show that screening helps with treatment, early on prenatal screening tools are crucial to allow prompt attention and interventions. Most women who live with somebody who uses drugs usually will also use drugs or be at higher risk. You also want to do a urine drug screen on them at the first prenatal visit, and if positive or if there's any type of history, you want to continually do UDAPs throughout the pregnancy. Prescription drug monitoring program is where you want to refer them to. Many places have them now. In Massachusetts, Boston has one at the Boston Medical Center, and they just branched out to South Shore Hospital in Weymouth. It is a bridge program, and the bridge program helps with women in pregnancy, following pregnancy, postpartum. They help with maintaining their program and their medication, counseling, anything they need. conversations with open-ended questions in non-confrontational ways. They don't want to feel judged. So they often have a fear of a stigma, so they don't like to admit to anything. In Coleman, 2019, he researched comparing screening tools and found that the 4Ps was the most ideal and effective tool for screening for drugs. Methadone versus Subutex. Methadone has been the preferred method of treatment, but they are finding that the Subutex or Suboxone, when compared to the methadone, resulted in significantly longer gestational age. So the baby did not come out as premature or made it to full term. 94% treated with this medication reported adequate prenatal care, meaning they weren't skipping their appointments, they weren't late entry to care. And it resulted, they found that their results that they had a less risk of potential for misuse, and it was much more easy accessible and requires less frequent medical follow-ups than methadone. Methadone is also throughout pregnancy, the amount can adjust. Subutex or Suboxone normally does not. So subjective and objective, they're going to have difficulty sleeping. They're going to have mood swings, depression. They're going to have a history of criminal activity. They're going to be fatigued or tired. They also have other children that may not live with them. They avoid prenatal care. They live chaotic lifestyles, frequent changes in addresses, looking unkempt, poor physical coordination. They may have poor malnutrition as well because they don't have the finances to have the proper nutrition. They can come in with bloodshot or glazed eyes, dilated or constricted pupils, or frequently missed appointments. If there was no prenatal care and a mother presents to the unit for delivery, we can test instead of because they missed the UDAPs, the urine test throughout the pregnancy. We can test the first stool of the baby, which is called the meconium. When the baby has that, we take the diaper and we can send that down to be tested. Alrighty, we also initiate medication when signs of withdrawing, and that is it. So we want to differentiate whether the diagnosis is abuse or other problems. As a provider, other conditions should be considered. They can look very similar. Depression, anxiety, PTSD, metabolic abnormalities like hypocalcemia or hypoglycemia, endocrine disorders. Of course, we want to test urine at the first prenatal visit, and if you suspect, you want to continually check. PTSD from trauma, a lot of women, physical, sexual, or emotional trauma. If they do have that, a lot of those women do end up on substance abuse. Infants also, no, that's it. Prenatal care monitoring for during antepartum. So, of course, with delivery, you want to continue with administering full dose of the Suboxone or Subutex. You don't stop during labor. You continually give it because you don't want to put them into withdrawal. The first trimester, you want to do your initial screenings. You want to do STDs, hepatitis, HIV, Hep B, chlamydia, gonorrhea. Those are all routine. TB normally isn't routine, but with somebody who is high risk, you should do it. Refer to maternal fetal medicine. Early on, you want them to build a rapport, and because they're going to continually see them throughout the pregnancy. Early ultrasounds to help determine gestational age, because later in pregnancy, they are at high risk of fetal growth restriction. And so we want to get the best estimated gestational age as we can. So the earlier on the ultrasound, the better that is. We want second trimester assess for growth, restriction, ultrasounds, start BPPs at around 28 to 32 weeks. 32 weeks is routinely when you start them, but with this kind of high risk patient, you are able to start them early on. Routine prenatal visits, UDAPs. Let's see, the third trimester, we want to repeat test for STDs. Normally, we do not do that in routine care, but with these high risk clients, we do want to set up anesthesia consults and NICU consults. Anesthesia may be difficult come the time of delivery for them to get comfortable, and it's good for them to review their plan of care prior. The NICU consult is also necessary considering the NICU. The neonatal intensive care unit, the baby will be going to the neonatal intensive care unit once withdrawal symptoms start to come on. Discuss contraception after delivery. That's very important. We're going to do NST weekly, BPPs weekly, because we want to stay on top of that growth, and we want to make sure that placenta is adequate and sufficiently growing and growing that baby as well. We want to do the UDABs. We want to discuss breastfeeding. Breastfeeding is okay with Suboxone or Subutex. A small amount of Subutex is passed to the milk, so only they say approximately 1%. So it is okay to have them on breastfeed. We will actually want to encourage it. So at all your appointments, you're always going to assess the patient's well-being, social, mental, and physical situations going on, and help counsel them. We do want to refer them to social services. Social services are going to be involved with them after delivery. Also, child welfare will be too as well. Legal factors. Has to do with the social services and the Department of Child Welfare become involved. These infants are the most vulnerable victims. They cannot speak for themselves, but we as providers and as caretakers need to make sure that that baby is going home to a safe environment, somewhere that they are going to be taken care of. They're going to be fed and cleaned, and that's everyone involved needs to make sure they stay on top of that. Also, providers will inform the PD services a possible neonatal withdrawal as well. But also the legal factors is if they are found okay to take their baby home, we do not have a right to keep their baby. So a majority of moms do take their babies home if they are in treatment with methadone or Suboxone. They are definitely able to take their babies home from there. Thank you, and I will take all questions at this time.